So, like we talked about last week, we are going to jump a little bit ahead of where we currently are in class, and we are going to cover neuromuscular disorders. So, some of this information you will see again next week in class as we look at um, the neuro system and then musculoskeletal as well. So, some of this will be in class next week, some of it is some extra as well. So the first disorder we're going to look at is Down syndrome. So this is when we have a trisomy of chromosome 21. So it means instead of having two copies of it, we have three. And it's one of the most common chromosomal abnormalities that we see in kids. It is classically characterized as having cardiac defects, respiratory infections. They have a difficult time feeding because they just have low tone in general. So they tend to be really floppy. They also tend to have a very large tongue for their mouth. So it makes it hard for them to get that good latch onto um, either a bottle or a nipple. They also have delayed developmental skills, cognitive impairment, and they can have some skeletal defects that go along with it. And one of the risk factors for Down syndrome is advanced maternal age, um, which is considered anyone over 35. And also, dad tends to be older as well. So, common physical characteristics, they have a flat, broad nasal bridge. So, this part of their nose tends to be flat and wide. They have inner epicanthal eye folds. So, they have an extra fold here, and they have this outward slant to their eyes. They have that big protruding tongue, very short, wide neck. And the big one that they have is they have a simian crease. So the transverse palmar crease, they will just have one line across the palm of their hand instead of two, like you and I have. They have hypotonia, so very poor tone. They're just floppy, kind of a big blob. And then that makes them to be pretty unstable. So how do we help these parents? We can help them with providing all those services to help with physical therapy, occupational therapy, um, monitoring their growth and development, teaching parents how to use a bulb syringe so that they can help clear the child's airways once they go home. They are going to be at high risk for respiratory infections. Their poor tone plus difficulties with feeding put them at risk for aspiration pneumonia. So difficulties with feeding, they might need to work with occupational therapy, using a special bottle, maybe a slower flow nipple, so that they can feed effectively. We always want to place them on their side when they're feeding, and then make sure that we're feeding into the side of their mouth, the back into the side of their mouth, so that they have lots of opportunities to manipulate that food. So our infants, we're going to feed them side lying and slightly elevated so that the milk all pools in their cheek rather than just going down the back of their throat. With an older child that we're feeding solid foods, we want to make sure that we're putting it kind of in that cheek pocket so that they aren't choking on it. Teaching parents how to look for signs of cardiac difficulty, respiratory infections, coordinating care. They're going to be involved with a lot of developmental therapies, early intervention programs to help get them set up for success before they even reach school age. And the overall goal for caring for a child with Down syndrome is putting all of these resources in place so that we can get them to their optimal level of functioning. Next up is going to be cerebral palsy. So this is a one-time injury. It doesn't progress, doesn't get worse. It's just a one-time injury to the motor centers of the brain. and it causes neuromuscular problems of spasticity and or dyskinesia. So spasticity is tension inside the muscle. It's not actually those jerking movements that we think of. It's the actual tension inside the muscle. So that electrical tension is what spasticity is. And then dyskinesia is involuntary movements. So something not purposeful. Typical causes of cerebral palsy, they have a traumatic delivery. So they're experiencing a prolonged time without oxygen, either before, during, or after birth. Or we have an excessive level of bilirubin that builds up and causes kernicterus. So that's why we test bilirubin levels right after they're born, and we keep trending them to make sure that they go down, so that we don't get that kernicterus where we get those bilirubin deposits in the brain and they don't allow our brain to function properly. The signals don't get transmitted well, and we aren't able to metabolize that bilirubin to get rid of it. Some other risk factors for cerebral palsy: if we are low birth weight, or if mom has an infection while she's pregnant. And long-term complications, we're going to have cognitive impairment, we're going to be at high risk for seizures, and also failure to thrive. So in order to assess for cerebral palsy, we need to test all of their reflexes, and they're going to stay in that neonatal stage. So typically we grow out of some of those very primary reflexes, but these normal reflexes that disappear are still going to persist after 6 months of age. So like our Moro reflex, our tonic neck reflex, those are going to stick around when they should have gone away. They're also not going to be making progress on their developmental milestones. So things that we expect them to do by their age, they're not going to be achieving. They will have an early preference for one hand over the other. So you'll see that happen before they get to 3. They also have poor suck. They tend to thrust their tongue, so their tongue will push forward, so they get a really bad latch. We see that muscle spasticity, so that tension in the muscles. So when mom goes to diaper the child, they're going to get real stiff. So everything's going to be tense. They're going to be stiff. So they're going to be considered difficult to diaper. And that's how parents are going to describe it. And that's just that extra tension in the muscles that causes that stiffness that would make it difficult to manipulate them around to do a diaper change. We also see scissoring of the legs as a very common characteristic of spastic CP. So our legs are going to be straight out and they're going to cross over each other, and our feet are going to be flexed. So that's going to be that scissoring with our legs. Also, those involuntary movements that we talked about, and also seizures are going to be an indication. So we want to make sure that we keep a close eye on our infants, especially our high-risk infants like our premature babies. We want to get all of our resources involved, coordinate with community-based agencies, those in the hospital, whatever resources we can get for parents. They're going to be involved with every type of therapist that you can think of: physical, occupational, speech. They're going to have a nutritionist to maximize their nutrition. A lot of that's going to be artificial. So they're probably going to have a feeding tube in their belly. Orthopedic surgeons to help with, and neurologists to help with that spasticity, making sure that we get good range of motion and muscle control as much as we can, trying to deter some of those contractures and things that make CP worse. So with our children with CP, they're going to be at high risk for aspiration because of the insult to their brain and their limited physical abilities. So we need to make sure that these kids are upright when we're feeding them. They might also need some extra support of their lower jaw to be able to move it effectively, to be able to chew and swallow their food sufficiently. And this whole process, this diagnosis, unfortunately, is a lifelong limitation that the child and their family faces. So they do need a lot of support, especially with the severely affected children that are wheelchair bound, total care patients, where they're relying on somebody else for everything to stay alive. So those can be very challenging and draining. We also, as we know, if we have seizures, then we can give anti-epileptic medications to prevent those seizures. So things like phenytoin, carbamazepine, um, dilaproic sodium, whichever the healthcare provider prescribes. And then if the patient has spastic CP and they're at risk for muscle spasms, so that extra tension causes their muscles to twitch, then we can give baclofen. And that helps to release the tension in the muscles so that we don't have those spasms. Next is attention deficit hyperactivity disorder, so ADHD. And that is a group of disorders all rolled into one. Originally, it was thought that these were a psychiatric disorder, thinking that it was a mental health issue, but we're now finding that it is a neurologic issue rather than a psychiatric. So that's really all we need to know about ADHD. Every child's plan of care is going to be a little bit different with ADHD, depending on their level of functioning, what they're responsive to. So just working with the care team and maximizing the best outcomes for that patient. So spina bifida is where we have a malformation of the vertebrae and spinal cord. So typically what happens is we have the most obvious is when you have a sac outside at the very tailbone of the patient, and you can see where the spinal cord kind of protrudes into this sac here. And we do have different varying types of spina bifida, but depending on the level of injury will depend on the amount of disability associated with it. So spina bifida occulta is where we just have a defect of our vertebrae. There's nothing outside the body, usually pretty benign, but they might have issues with walking and bowel and bladder training. If we have a meningocele, we have the meninges and spinal fluid that are in this sac outside of the body at some point along the spine. Typically tend to be in that lower back area. A myelomeningocele has those meninges, the spinal fluid, and the nerves from the spinal cord are all inside those sacs. So depending on what portion of the spinal cord is exposed will dictate which type of spina bifida that you have. And depending on how far up or down the spine it is will dictate where you're going to see those defects and that impairment. This is easily treated by taking folic acid throughout your entire pregnancy. So as soon as you confirm that you're pregnant, you definitely need to be maxing out on folic acid. It's actually recommended that if you're thinking about pregnancy, that you go ahead and start taking folic acid before you even get pregnant, because the spine is one of the very first things that develops in the fetus. So risk factors, females are more at risk. Hispanic or Northern European Caucasians are most at risk. Like we said, it's from a folic acid deficiency. Maternal obesity and diabetes also are risk factors. And then the complications, we see hydrocephalus where we get fluid in the brain. And that is extremely common if you have a myelomeningocele. They pretty much go hand in hand. We get some form of neurologic impairment. Typically, they have a neurogenic bladder, which means they don't have any control over their bladder for the most part. They can't tell when it's full and it needs to be emptied. And we also have poor anal sphincter tone. They tend to have dislocated hips at birth and clubbed feet and lots of skin problems below their defects. So if you think about all that exposed skin and poor bowel and bladder control, it puts you at high risk for skin problems. They're also at risk for scoliosis because they have a skeletal deformity. And then these patients all have latex allergies. We automatically put them in latex precaution. Highly sensitive to latex. So with spina bifida occulta, you might just see a dimple, a sacral dimple. It may or may not have a hair tuft kind of at the base of the spine there. If you see a sac, you might have a meningocele or a myelomeningocele. You can also see flaccid paralysis where they just have no movement at all, or they will be limited below that defect. So typically it just happens below the defect. So they'll have control over their upper extremities, but they won't have any control over their lower extremities. And then depending on whether or not they have hydrocephalus as well, will dictate whether or not your head circumference is normal. So before we go to surgery, obviously we're going to have to correct this. So surgery is going to be our only intervention here. So before surgery, we want to keep that sac nice and moist, sterile dressing so that we can protect it and protect the spinal cord. We want to make sure we don't get any urine or stool on that sac because it could get into the spinal cord. These patients will be prone or maybe side lying so that we're not causing any tension or putting any pressure on that defect. We're going to be doing intense neurologic checks on these babies. We're going to be measuring their head circumference frequently and checking those fontanelles with every assessment. We're looking at their neurologic function, watching for signs of infection. That's one of their biggest complications. We are going to help them with emptying their bladder. So one of the things that you can do is you can kind of reach the bladder above the pelvis and you can put pressure on it and help them to push. The pressure that you exert will help them to empty their bladder. If that doesn't work, then we can catheterize if we need to. And then promoting that parent-infant bonding. It's really difficult when your child can only be prone, side lying. You have a big defect that you're nervous about, but we really want to promote bonding. Postoperative infection control is going to be huge. Watching that neurologic function, taking care of that incision, and promoting bonding. Long-term care for these patients, we're going to have to teach family how to catheterize because they're probably going to need to cath at home. Eventually, the child will be able to self-cath to empty their bladder. We're going to give medications. We do have medications that we can give to improve their ability to have bladder control. So propantholine or bethancanol are the two medications that we can give. We're going to implement a bowel program. So we're going to have this regulated program that we use to keep our bowels on a normal schedule so that we know that we're able to empty our bowels. So we're going to promote a high fiber diet. We know fiber helps clear things out of our intestines. We need lots of fluids to help move that stuff through. We can also use suppositories as we need to help stimulate that anal sphincter and make that bowel movement happen. These kids are going to need really good skincare, making sure that we have a latex-free environment. They're going to need help with range of motion where they don't have control over their extremities. They might need some help with ambulation, special braces to help them. We want to support the independence of that child as much as possible and develop realistic goals with the family for their expectations of the child's function. So we talked about prevention. It is folic acid at least 3 months before pregnancy. So if you're thinking about getting pregnant, definitely start your folic acid right away. If you get pregnant by accident or unintentionally, then definitely as soon as you know, start that folic acid so that you can reduce this risk. So hydrocephalus, one of those complications of myelomeningocele. This is where we have an abnormal amount of cerebrospinal fluid in the ventricles of the brain. So we have an obstruction in the flow of that CSF between the ventricles, which causes them to enlarge and puts pressure on the brain tissue. So spina bifida, meningitis are the two main risk factors. And the major complication of hydrocephalus is that increased intracranial pressure. Our signs of increased intracranial pressure are going to be opposite of shock. So in shock, we know we have an increased pulse and decreased blood pressure. With increased intracranial pressure, we're going to have a decreased pulse and an increased blood pressure. So in infants, when we're assessing, we're going to notice they're either going to be really irritable or really lethargic. They're one end or the other. Their head circumference is going to consistently get larger at a rapid rate rather than just that normal growth that we expect. They're going to have bulging fontanelles. So they're going to have that rounded dome. You're going to be able to feel that fontanelle pushing out from their skull. They're also going to have widening suture lines. So you should be able to feel a slight indentation where the infant's sutures are. So where their skull hasn't fully fused together, you should be able to feel a very small indentation. Well, with these patients with severe hydrocephalus, I mean, they can be 1 to 2 finger widths apart. So it's a very large gap between those suture lines. They also have sunset eyes where their eyes tend to be turned downwards. They kind of hang out in the bottom half of their eye. And they have a very high-pitched cry. The high-pitched cry is one of those telltale signs of that increased intracranial pressure. In our older kids, you'll notice a change in their level of consciousness. They may be irritable, have vomiting. One of the classic signs is that headache when they wake up. Difficulty with moving. You may notice an unequal pupil response, some seizures, changes in their personality or school performance. And it's really important that we know what their usual behavior is, their normal developmental level, so that we know when these changes happen, so that we can assess their intracranial pressure. So our interventions, we're going to prepare the family for all the diagnostics that we're going to do. We're going to watch for those signs of increased intracranial pressure. These patients are going to be on seizure precautions just because they're at high risk. We also want to keep the head of the bed elevated, so we're promoting drainage and not putting extra pressure on the brain. You know, if your head's down, then all the blood rushes to your brain. You get that dizzy feeling. We want to avoid that, so we're going to keep our head up. And then we're going to prepare for surgery. So sometimes we need to surgically intervene for hydrocephalus so that we can alleviate that pressure. So we're going to insert a shunt into that ventricle. So that's just going to be a little device that is connected all the way into the peritoneum, which is like our abdominal cavity. And that's where we're going to artificially drain that extra CSF fluid. So that shunt is going to suck out that fluid and drain it into the peritoneum so that the body can absorb it. So after we have that surgery, we want to make sure that that shunt is working properly. We're going to be looking for signs of infection. We're still going to be looking for those signs of increased intracranial pressure, measuring our head circumferences. Those are all going to be signs that our shunt is either working appropriately or it's not. We're going to be looking really closely at our I's and O's. It's very, very important that we never pump a child's shunt unless the physician tells us to. So the shunts are extremely delicate, and as we pump them, we're causing pressure changes within those ventricles. So it can be extremely uncomfortable for the patient, really unsafe if we're artificially interacting with this. So we also need to teach parents plan for home care, teaching them what those signs of increased intracranial pressure look like, signs of infection. Eventually, that child will outgrow their shunt and it will need to be revised, and they'll put a bigger one in. So they're going to show some of those symptoms that we talked about. So we also need to help them with potential growth and development issues that come along with it, looking out for those signs that we need to revise that shunt or that it's not working appropriately. With seizures are very common with hydrocephalus because we've got that increased pressure in the brain. And we talked about the causes where we've got that obstruction in flow, increased enlargement. This is the exact same slide. Our seizure causes can be associated with our immaturity of our central nervous system, fevers, infections, neoplasms, so abnormal growth in our cells. We can have a prolonged period where we don't have oxygen to our brain, and also a complication of metabolic disorders. So if we aren't metabolizing things effectively and they build up in our brain, then we can result is seizures. So seizures tend to be more common in kids under 2 if they're going to happen in our pediatric patients. And we have a couple different types. So the typical tonic-clonic seizure, that's that normal convulsive seizure. You may have an aura, which is some sort of a warning sign that you're going to have a seizure. You're typically going to lose consciousness. We have a tonic phase where we're really stiff. And then that clonic phase is where we have those spasms and then all of a sudden we relax. You can also have apnea and cyanosis. Our pupils are not going to be reactive. They're going to dilate. A lot of times we lose bowel and bladder control at this point. And then after the seizure, we have that ictal stage where we have, or post-ictal stage where we're disoriented and sleepy. So tonic-clonic seizure is the typical what everybody thinks of with a seizure. An absent seizure is only 5 to 10 seconds long, and the child appears either inattentive, like they're daydreaming. These are also called focal seizures. And we tend to not realize these children are having these because they'll just kind of stare off into space for 5 to 10 seconds and then they're back. So you may just see those eyes deviate and they're going to kind of lose focus for 5 to 10 seconds and then they'll be right back with you. So a lot of times it just seems like they're daydreaming. So we may have our first assessment is our performance in school. So that might be the first indication that we might have something going on. We can diagnose seizures with an EEG, which looks at the electrical activity in the brain, or we can do a CT scan. With seizures, the most common cause of increased seizure activity is not being compliant with medications. So in the event that the patient has a seizure, we want to maintain their airway. We want to try and get them on their side so that they're not aspirating on their secretions. We want to make sure that we're not restraining them. We can cause more injury to them, but we still want to make sure that we're protecting their head and their neck during that seizure so that they don't hurt themselves. We want to observe and document everything about the seizure. When it started, was there anything that led up to it? What did it look like? What were the vitals during that time? How long did it last? Is there anything that made it better? All of those things need to be documented. And then they're going to be in seizure precautions. So we want to reduce all environmental stimuli, anything that can put extra stress on the brain. We want to pad our side rails, make sure we have suction and oxygen ready at the bedside. They also need an alternate airway at the bedside as well in the event that they can't maintain their airway. Remember never to put anything in a patient's mouth when they're having a seizure. It could cause damage to the mouth. We could cause them to choke. And one of the things that we're going to do is rule out any cause of infection. So we're going to try and rule out things like meningitis as a cause for our seizures. We're going to give our anticonvulsants as prescribed. So for our tonic-clonic, you can see the medications that we would use. We have less available that we can use for absent seizures. And these medications can build up in the body. So we have to keep a very close eye on our therapeutic drug levels. So we have to get to a certain level of medication to make sure that it's effective and it's controlling our seizures, but we don't want to go too high or too low because we risk reaching toxic levels or not controlling our seizures at all. So keeping an eye on those medication levels and then helping parents understand the importance of sticking to the schedule, how to administer it, what the dosage is, how to measure that, how it works, what the side effects are. Those are going to be really important, especially when you're between those lab days. So looking for those signs of too much or too little medication. Next is bacterial meningitis. So we've got inflammation of the meninges that cover both the brain and the spinal cord. It is typically a bacteria that gets introduced either through the ear or through the nasopharynx. And it puts this nasty goo all over the brain, and that causes our brain to swell. So our causes of meningitis, typically it's going to be Haemophilus influenza B, strep pneumonia, or Neisseria meningitis. Other bacterial sources could be from wounds, especially if we have a fracture to the skull, or from lumbar punctures or those shunts that we have to insert for things like hydrocephalus. Other risk factors, meningitis is still very prevalent in Africa, so traveling to Africa puts you at more risk. Also, if you're immunosuppressed, obviously you're going to be at more risk for acquiring an infection. If you have a head injury or brain surgery, those are going to put you more at risk. Complications, we can end up in DIC where our blood doesn't clot anymore. We can have encephalitis, have a fever, risk for seizures, and syndrome of inappropriate diuretic hormone. So we have a whole cascade of events that happens with that as a result of our antidiuretic hormone not working properly. So when we test for meningitis, we are going to look at our white blood cell count, and it is going to be elevated. We're going to have a low glucose, increased protein, increased intracranial pressure, and then we're going to get that positive blood culture or spinal fluid culture for meningitis. Infants have an absence of those classic signs. They're very generic in how they present. They're going to have poor feeding, vomiting, irritable. They're going to have that bulging fontanelle. That's going to be that sign of increased intracranial pressure. And they can present with seizures. So just in general, they kind of just don't feel good. They present with very general symptoms. Older kids, they're going to be more classic. They're going to have the fever, the chills, the stiff neck. They're going to be sensitive to light, positive Koenig sign. So if you flex your thigh at the hip, you can't extend your leg out. Radinsky sign is if your neck is flexed, it causes adduction and flexion movements of your lower extremities. So these patients are going to be on antibiotics and antipyretics. They have to be in isolation for 24 hours past the start of their antibiotics. We're going to be doing very frequent vital signs and neuro checks on them. They need a minimal stimulation environment. So quiet, dark, very little interaction going on with them so that we can just let their brain rest. We don't want them taking in any form of stimulation. They're going to be on seizure precautions. We want to keep the head elevated just a little bit, maybe place them on their side if that's more comfortable. We're going to be doing at least daily head circumferences, keeping a close eye on our eyes and nose. And then one of the things that we can do to prevent that Haemophilus influenza infection is giving that Hib vaccine. So making sure they're up to date on their vaccinations. We have to keep a very close eye on their hydration status because we can get that inappropriate antidiuretic hormone, which can cause.
Professor,
Yes.
I have a question.
Yeah.
When you say to elevate the head of the bed just a little bit, how like 15, 30 or 45, something like that?
Somewhere between 15 and 30. Yep.
And 30.
Yep.
Okay, thank you.
Yeah. So that antidiuretic hormone, if it is flowing at an inappropriate rate, then we can end up with fluid retention. So it's going to cause more swelling in our brain. And it also will cause our sodium levels to drop. So our sodium gets diluted out by all that extra fluid that we're retaining. So here are some common seizure medications. So we talked about phenobarbital is for those tonic-clonic, can also be used for partial seizures. It is going to be that long-acting medication. Typically, we combine it with other medications as well. Some of those adverse reactions we need to look for: drowsiness, nystagmus, where your eyes are just wiggling, ataxia, you have difficulty speaking, paradoxical excitement, where we all of a sudden have this reverse effect. We're giving you a downer and all of a sudden you're up, you're really, really hyper. And then our therapeutic levels are 10 to 25 micrograms per milliliter. Phenytoin is another one that we can use. We have to watch for gingivitis with this, dermatitis, nausea. It can also cause bone marrow depression. This one interacts with a lot of other medications. So we have to keep a very close eye on patients that are on phenytoin, that they don't have another medication that could interact with it. They need meticulous oral hygiene because of that risk of gingivitis. And we're going to have to do routine CBCs so we can watch for that bone marrow depression. And this is one of those medications that does not play nice with milk. So you cannot give milk at the same time that you give phenytoin. Fosphenytoin is a different medication altogether. It is used for generalized convulsive status epilepticus, so prolonged seizures that last for more than 30 minutes and aren't responsive to medications. That's when you're in status. We can also use it as a preventative when we're doing neurosurgery. So anytime we're manipulating or irritating the brain, we're at risk for causing seizures. And it is going to be a short-term replacement for oral phenytoin, which is Dilantin. So if we need to give that some other way, then we can use fosphenytoin. and it is a rapid IV infusion. Can cause hypotension, um, can cause ataxia, CNS toxicity. So we get confusion, all the same things that we had with phenytoin, where we've got the gingivitis, irritable. We can also cause lupus. You might see nervousness, Stevens-Johnson syndrome, and toxic epidural necrosis, where we've got skin breakdown, skin death, tissue death around that epidural site. So we only use this medication for short term. It's a last resort, either IV or IM. And we should always make sure that it is dispensed in its own measurement. So the phosphonatoin sodium equivalents. Valproic acid is for absent seizures or myoclonic seizures. It's very damaging to our liver, especially if we're under 2 when we are still immature, and it can prolong our bleeding times. So we have to do liver function studies, and it will make phenobarbital and dilantin work faster. So it potentiates them and alters their blood levels. So those medications are going to be at risk for reaching toxic levels a lot faster if you're also giving valproic acid. So it speeds up their metabolism. Carbamazepine, tonic-clonic and mist seizures, causes drowsiness, can also put you at risk for hepatitis and agranulocytosis. So again, keep an eye on our liver function. Levectrin is for partial seizures, myoclonic and tonic-clonic, can cause depression and dizziness. It's going to be one of our oral or IV meds. This is one that we can't abruptly discontinue. You never want to abruptly discontinue a seizure medication. You're at risk for going into status doing that. Again, keep a close eye on our liver, our red blood cells, our renal function periodically. And our last medication is clonazepam. Can cause drowsiness, also hyperactivity and agitation, can make them salivate a lot more. Another one that we don't discontinue abruptly. Moving on to Rye syndrome. So this is encephalopathy and hepatic dysfunction caused by aspirin in the presence of a viral infection. So if we have a patient with flu-like symptoms and we give them aspirin to try and counteract those flu-like symptoms, we can cause Rye syndrome. So influenza, chickenpox, any viral illness, in the event that we're also giving aspirin, we can cause this. And the severity of the condition is going to depend on the clinical signs and symptoms that we're seeing. It's going to be more predominant in our school-age kids. So we can see some elevated labs here. So our AST and our ALT go up, our lactate, our ammonia, but we are going to have a decreased prothrombin time. So we're going to be at increased risk for bleeding. We can be lethargic, progressing all the way to a deep coma if we have a lot of swelling in our brain, vomiting, hypoglycemia, all very common. So we need to get these patients in our care very quickly. We're going to keep a close eye on their neurostatus. We are going to monitor their intracranial pressure. We may have to artificially ventilate them. They're going to be on a cardiac monitor, keeping a close eye on their function. We're going to do strict I's and O's. They're going to have a Foley catheter so that we can keep a very close eye on their output. And then this is very traumatic for families, so providing that emotional support. Brain tumors are the second most common form of cancer in children. Most are difficult to surgically remove. They're usually close to vital structures which make them really hard to surgically remove without causing permanent damage. Gliomas are going to be our most common brain tumors. They can be genetic causes. They can be caused by other forms of cancer that metastasize. Our risk factors are going to be radiation exposure and those genetic diseases. Complications are neurologic damage, infection, and bleeding. Also, headaches. So, a headache upon awakening is the most common presenting symptom of a brain tumor, often associated or goes along with vomiting in the morning. Even though the patient may not be nauseous, they have a hard time focusing. You might notice changes in their personality. They might have vision problems. They might try and tilt their head to correct their vision, or try and block one side of their brain so that they can focus a little bit easier. In infants, you're going to see the same thing that you do with the hydrocephalus. You're going to see those widening sutures. Their head circumference is going to increase. They're going to have that tense, bulging fontanelle. They might have changes in their gait or how they walk, might not be able to do things that they normally should be able to do. So it's important that we know what their baseline function is. We know what they're capable of doing so that we can identify those things that are abnormal. We may have to do surgery. So we want to reinforce that pre-op teaching. So we're going to have to shave their head. We're going to be in the ICU. We're going to have lots of IVs and dressings, explaining all of those ahead of time because it's very, very traumatic to see your child like that. Making sure that we know their developmental level and plan teaching accordingly so that we know what that baseline is, so we can teach them what abnormal looks like. Parents will need lots of support with coping with the diagnosis, making sure that we've got everybody involved with them. After surgery, you're going to follow the provider's instructions for positioning, especially if they have a large incision on one side of their head. We're not going to be able to put them on that side. So most of our patients are either going to lie flat on their back or they're going to turn to one side. Like I said, if we have a large tumor that had to be removed, we might not be able to lay on the operative side. We're going to keep a very close eye on our I's and O's because if we end up with overhydration, we can cause more swelling in the brain and increase that pressure. We're going to give steroids to keep that swelling down and promote optimal functioning for that child and their family. We need to know activities that increase our intracranial pressure. So suctioning, coughing, straining, or turning our head. So if our head is outside of midline, it can increase that pressure in our brain. Almost there, guys. Muscular dystrophy is an inherited disease causing our muscles to deteriorate. So they get this progressive weakness. The most common is Duchenne's muscular dystrophy. And it is an X-linked recessive trait where we've got a mutation in our gene. It's predominantly found in males in early childhood, so somewhere between 3 and 5, and typically gets passed through the family. So if one male child has it, the others are going to be at high risk for it. Complications of that progressive muscle weakness, we get respiratory distress, cardiac distress, and then it eventually leads to death. We can diagnose this with a muscle biopsy. We can also see elevated creatine phosphokinase, or CPK, AST, and ALT. These patients have a very waddling gait. They kind of waddle like a penguin. They have lordosis, which is that big curve in their spine. They're typically clumsy, and like we said, they've got that progressive muscle weakness. So we see them having a hard time getting from the floor up to a standing position. So one of the things that we look for is Gower sign, which is that difficulty getting up into standing. So they're going to have to work their way up, like walking up their legs using their hands. They'll walk themselves up furniture, trying to get from that floor up to a standing position. They also have hypertrophied calf muscles, but that's just because of the fat deposits that end up in our calves. Their muscles start to degenerate, they break down, which is what we're detecting on that muscle biopsy. They have delayed cognitive development. And then as the disease progresses, we'll see the scoliosis in the spine, we'll see respiratory difficulties and cardiac difficulties. And the child will eventually be dependent on a wheelchair and then finally confined to bed as their weakness progresses. So for these patients, we're doing supportive care. We're going to do lots of exercises to keep their muscles going to try and prevent some of that weakness. We want to make sure we protect them from infection, so no respiratory infections. Encourage a balanced diet so we're not causing obesity and putting extra strain on those muscles. And this is going to be a terminal illness for this child. So the family is going to go through grieving. So we need to support them in that process and get them connected with resources like the Muscular Dystrophy Association that can help them with caring for their child and getting them in touch with other families that have gone through this for support. That is all I have for you guys tonight. Do you guys have any questions on anything that we covered?
Not ready for me.
Okay.